Hello guys, I am Samkit Jain and I'm a medical student at Mindz National Medical University. And our today's topic for the conference is brachial plexus. And I am an educator at Inspiring Minds where I teach anatomy. So we'll discuss about the anatomy of brachial plexus for now. So brachial plexus is basically a plexus of nerves. It contains somatic nerves. Somatic nerves are the nerves that supply our skeletal muscles. So it contains somatic nerves that supply most of the skeletal muscles of your upper extremity. Now, where these nerves come from? They come from the ventral rami or the anterior rami or C5 to T1 spinal nerves. These spinal nerves they combine, they divide into various trunks, divisions, and then they finally gives off cords, and cords finally divide into various branches. So if we talk about the five terminal branches, the brachial plexus gives off five terminal branches that are musculocutaneous nerve, axillary nerve, radial nerve, ulnar nerve, and median nerve. And we have very much importance of all these nerves that are provided by brachial plexus, because suppose if there is any injury to ulnar nerve, if there is injury to ulnar nerve, then we won't be able to do the abduction and adduction of our fingers. Why? Because ulnar nerves supply our interossei muscles, and interossei muscle helps in the abduction and adduction of the digits. So any injury to the ulnar nerve, there won't be any abduction and adduction possible. Similarly, radial nerve supplies your extensors. So if there is any injury to the radial nerve, your arm will be permanently flexed. So these are some of the anatomical concepts, and I would like further educators to proceed.
Samkit, I wanted to ask you that whenever we talk about the brachial plexus, so there was one question and there was a term used, cord. So what I mean, what does it mean that cord?
Cord, basically what happens that your brachial plexus is divided into four parts. One of them is the cord. The terminal part of brachial plexus is the cord. So what happens, there are roots of the spinal nerves. Those roots they continues as trunks, and trunks, each trunk divide into an anterior division and a posterior division.
Mhm.
These divisions they finally continue as the final part of the brachial plexus, that is the cord. And these cords they end in your axilla. These are basically the contents of your axilla, and these cords finally give the branches, the main branches of your brachial plexus.
Okay,
Okay,
so
I would like
cord,
to.
yeah,
Okay,
some.
you proceed. Okay, so I like to add something that you said something that it has motor divisions, like it is supplying the motor output also, and the brachial plexus it is also important because it is supplying the sensory output also to the upper limb,
Yeah.
and also some sympathetic branches. Yeah, sympathetic nervous system that we have. So from the
Yes.
cervical angle we are getting the sympathetic branches. So three type of what we say, the nerves are there, three type of neurons are there. So if there
Mm-hmm.
is problem with any of the nerve, so you have good chances to lose the motor innervation plus the sensory innervation and the sympathetic innervation also.
Yeah.
Okay, that's the thing. And what type of injuries that can occur, it depends on what other things,
The type of nerve that is injured.
and it depends also.
So is it normal? I mean, that nerve injury to the brachial plexus, is it common
No,
or?
it occurs in certain scenarios, like if there is suppose there's a palsy, that is Erbs palsy. In that
Mhm.
palsy your three nerves are injured mainly, that is axillary nerve, radial nerve, and musculocutaneous nerve. And due to the injuries of these three nerves, each nerve produces a certain manifestation that are combined together and they come out as a palsy, and we call it as Erbs palsy.
Yeah.
Okay, so
Yeah, I want to add something, Samkit. Generally, during the labor, it can also occur because, like, at the third stage of labor, there is a strong contraction, and generally, the posterior shoulder is mainly affected because the posterior shoulder will stuck at the sacral promontory, and when they try to push, it will not able to push the fetus. So doctors only do some maneuver, that is Mac maneuver. In this they just hyperflex the female leg and they just try to pull the fetus, and when they usually pull the fetus, the brachial plexus can be damaged in that case also. And the most common risk factor in gynecology is like multiple gestation can also lead macrosomia usually we see in the diabetic women, babies. So these are the most common
Okay,
main
so
risk factor in
Okay.
this case.
Yeah, yeah.
okay, yes. So I think like if you have more than one babies delivered, there are more chances of injury because if they are twins or they are triplets in the what we say womb, so if you are delivering them, so it is more probable that you are going to injure those roots of the brachial plexus because more than one baby contributes to it.
Yeah, even the prolonged labor can also lead to brachial plexus injury.
Okay.
Yeah.
So I would like to add one more point over here.
Mm,
That just knowing the branches is not important. If you want to become a surgeon, the course of each nerve in relation to artery and veins is also important, right?
mm,
Hmm.
Like some kid, for example, can you tell where the roots are actually located, where the cords are anatomically located with
as
relation to clavicle?
Yeah, like
okay,
roots are
as
present
far as
in the
I know that
interscalene triangle
okay, as far
between
as
the
I
scalene and anterior medius muscles. They are present in the interscalene triangle. Cords are present in the axillary, in the axilla. They are the contents of your axilla.
okay,
Right,
and
right.
okay,
And
okay.
similarly, trunks are present in the posterior triangle of the neck.
Exactly.
Yeah.
Exactly. Right.
So till the trunk we have, uh, above the clavicle. The trunks are above the clavicle, and
Yes.
then from below the clavicle, the other parts continue.
And yeah, just I was having that query. When we talk about the cord and the like normal fracture, we see
Mhm.
that like hand fracture. So is there any contribution of only brachial plexus or somehow spinal nerves are also involved? I mean, separately cranial nerves. Sorry, cranial nerves. Just I
In
mean
the
to ask.
paral,
No, not paralysis. In like traumatic condition in surgery, someone is having a fracture to the upper limb. So is it possible that that moment that cranial nerves will be also damaged, or there'll be injury in the cranial nerves?
it can be there according to what we say. If the person is having some road accident, so if his upper limb is injured and he has some injury on the back, so what we say, the cervical part of the vertebra and above that. So in that cases, if you are producing an injury to the brainstem and all the above structures where you have the nuclei of the cranial nerves, so in that case the injury can be anything, and according to the case you have to look out, you have to check the various reflexes and the reflexes associated with the cranial nerves, and then we'll come to know that okay, the injury is brachial associated or some cranial root is also involved.
So the basic point is uh, the hand nerves usually present early after injury, but if there is a spinal injury, like in case of accident, unless
Mhm.
and until the cranial nerves or the nerves from their roots are compressed by the broken piece of vertebra, they compress it until and unless then no symptoms are developed. They generally develop later on, not exactly
Okay.
at the time of injury.
Mhm.
Okay.
Okay.
So there is chances, right?
Yes.
Mhm.
Okay.
What
So
symptom?
other things that can happen is like what can be the condition that can damage these nerves. It can be some tumors also, as I read from the pathology that some tumor or any space of lesion is there, and if the tumor is compressing the root, depending on what root it has compressed, it can give the presentation of the paralysis and the loss of sensation. Yeah.
And some could tell us something more about brachial plexus. I mean, they're in hand level, palm level.
Yeah, in palm. Okay. So in palm brachial plexus, if we talk about that, then in palm there are three nerves that are providing the cutaneous supply. So if we see, then your lateral 2.5 or 3.5 of the palm, the fingers are supplied by your median nerve, as well as the palm also, the skin of the palm of
All
lateral two
fingers.
and a half or sorry.
Just repeat that. All fingers supply from that.
No, no, no. Lateral 2.5. That is your thumb, your index finger, and your middle finger, and some in some cases the
Mhm.
radial side of your ring finger is supplied by your median nerve, and also the lateral. Similarly, the lateral 2.5 or 3.5 of a palm is supplied by the median
Mm-hmm.
nerve.
Okay.
Similarly, the nail beds on the dorsum of your hand are supplied by
Mm-hmm.
median nerve. Not entire dorsum of your hand is supplied by median nerve, but just the dorsum of the,
Mm-hmm.
but just the nail beds. Similarly,
Okay.
if we talk about the radial nerve, then radial nerve give cutaneous branches to an area very near to the first metacarpal, and it supplies the lateral 2.5 and 3.5 of the dorsum of hand. The lateral 2.5 of palm was supplied by the median nerve, but the lateral 2.5 of dorsum of hand is supplied by the radial nerve. Whereas the rest over part, that is the medial part, is supplied by the ulnar nerve.
Mm-hmm. Okay.
Medial part.
Similarly, ulnar nerve also give branches to your third and fourth lumbricals. Lumbricals basically helps in
Mm-hmm.
the hyperextension at the
Yeah.
interphalangeal joint. And
Okay.
similarly, the interossea, all the interossea, we have four palmar and four dorsal
Mm-hmm.
interossea. All these are
Yeah.
supplied by the ulnar nerve. If there is any injury to the interossea, then there won't be any abduction or adduction of the fingers.
Okay.
And the starting two lumbricals, that is L1 and L2, they are supplied by the median nerve.
Mm-hmm. Okay. And okay, I like to add something that guys, like we are talking about the paralysis of the brachial plexus and all these things. So according to the pathology, these nerves of brachial plexus, they are all peripheral nerves. Yes. And the compression is only the one type of injury that can produce the paralysis. So according to the what we say pathological terms, it is called as compression neuropathy. Compression neuropathy means that because of any type of compression, the nerve is compressed and it is producing the clinical manifestation. But there can be other causes also, pathological causes, that without compression or without any surgical intervention or without any trauma, there can be the paralysis of your limb. So do you know guys any such type of condition that can be there? There is no compression, there is nothing like that, but still the paralysis is there. So so it is okay. So it is like called as inherited peripheral neuropathies. Inherited means it is gene defects. So we know the axons are there, the nerves are made up of axons and the cell body, the neuron structure. So there are some genes that are encoding for the myelin proteins, and they should be well encoded. There should be no mutation in those genes so that the nerve impulse can travel properly. Yeah. So in some patients what happen is these genes are not there, there is loss of function, or by birth they are having the problem with their limbs because everything is normal, the nerves are well formed, but the genes that encoded for the myelin of the neuron, it is not functioning. So without compression or without any type of surgery, there can be inherited peripheral neuropathies. This is a group of diseases. There are many genes that they have discovered and that can be associated with it. Also, you can say, some autoimmune diseases that may damage the neurons. So if the neurons of your upper arm is damaged, or the neurons that are involved in brachial plexus, yeah, if you are damaging that, there are autoantibodies, we know that autoantibodies are produced, or it can be some T cell mediated injury also. So all of them can damage it. And then you will have to be very careful because in this situation you are not going to find anything that any injury is there or the patient has some trauma. So you must think about some other pathological causes also, that whether it can be inherited also, it can be autoimmune also, or T cell mediated injury can also be there. Yeah. So it is not that always it is due to compression or some laceration to the nerve. It is not like that. And some infections also, a very common infection, that is mycobacterium infection. Yeah. Mycobacterium leprae is there, and that Mycobacterium leprae, it also damages your nerves. So you have to see all the aspects that can cause the paralysis. You have to include the microbiology, and you also should be thinking about some toxic agents. Lead also, mercury, for example, and arsenic. They have very high tendency to do these damages. So what can be there is that the proper patient history should be taken from the birth to whatever the stage is there, and then you should do some differential diagnosis. Okay, maybe this is due to a toxic injury, or maybe autoimmunity, or maybe some infectious agent. So this is all the pathological relevance of the upper arm injuries or upper arm paralysis, is loss of sensation, anything.
So somehow
And
what?
some conditions are also like arthritis or some joints. So that will be also compression injury because of arthritis. Some nerve that is there and moving there, so it gets compressed. So you
Mhm.
should also think about the pathological situation. The patient has some pathology or a history of.
Okay. And so would you, sir, please, would you please tell us something surgical approach while having, upper limb injuries, etc.? Because we don't have that much knowledge right now. I think some kids also don't have the
I
surgical
think
approach real
Kostak will
knowledge.
be able to do it well.
Mm. No, just before
Yeah.
that as a theoretical, and also you
Yeah, so
can.
the first most important thing to look at such conditions is what is the basic site of injury. Like,
Yeah.
for example, if I have operated a patient who has some cystic lesions in the posterior triangle, or I have done a neck dissection, and after that the patient is coming to me with symptoms suggestive of your brachial plexus injury, then definitely some problem intraoperatively related to the upper and middle trunk of the brachial plexus is going to be the main cause. So the first important thing as a surgeon to look to such cases is what is the basic site of injury,
Mhm.
Yeah.
especially in surgical cases. Medical cases, you may not be able to find that, but in surgical
Yeah.
cases, yes, it is important. Like, one is posterior triangle, second is in the axilla in mastectomy. Most of the time in the
Mm-hmm.
axillary dissection, we injure the thoracodorsal nerve, we injure the nerve of bell leading to winging of scapula, which is one of the most important questions asked many of the times. Then it could be at the flexor retinaculum as well, when you are um,
Mm-hmm.
doing the external fixation in
Yeah.
fractures associated with radius and ulna. And
Mm-hmm.
also one important surgical approach, not necessarily in general surgery but related to orthopedics, is if it's a forearm fracture, you
Mm-hmm.
always have to fix it before surgery. For
Mm-hmm.
external fixation, what you need to do, you need to balance the equilibrium by the muscle. Like, for example, if you are having a distal radial fracture, what you need to do, you have to give a hand-on position to the patient, hand upward like this, such that the brachioradialis will pull on the opposite side, and that will prevent a compartment syndrome. And compartment syndrome can also cause injuries, right? Because all your nerves are passing through different compartments.
Okay.
Okay, so basically,
And
when we provide, while providing,
okay.
while doing the surgery, so we do that local anesthesia. So that anesthetic content, that place is near hand, or we do general anesthesia.
That depends upon what kind of injury and what other comorbidities or hemodynamic stability of the patient is. If the patient is hemodynamically stable, it's a lesser amount of injury. He can the repair can be done under local anesthesia. Then the nerve which is slightly near that injured site, we can use a local anesthesia in that cases. But if, especially if there is a complete transection and we need to do a nerve transplant, and in such situation we need to go for a general anesthesia.
Okay.
Okay. And okay, I'll like to ask one thing, that if the nerve is transected, okay, for example, a radial nerve or any such nerve, so
Mhm.
is there any chances of repair of those nerves? And as far as I know, that if the axon is damaged, it is cut. So the two parts that are there, the cut parts, they should be in proximity with each other. They should be nearer
Yes.
to each other, and if they are nearer, they can regenerate. But if they are far away, so there is very less chance to regeneration of that extent.
Yeah.
Mhm.
Yeah, basically the two ends which we are going to anastomose, nerve anastomosis,
Yeah.
what we are going to do, they should be matching with the circumference, and the second thing, that two ends should be at least 0.5 centimeter close to each other. And in
0.5
that case,
centimeters.
0.5 centimeter close to each other, then you can easily anastomose them by clipping, or some nowadays laser beam can be used. Some creams are available with which we can join the nerve ends. Or else, if it is more than that, but the circumference is clean, the cut ends are clean for that nerve, we can also go for a nerve transplantation. Mostly we use a sural nerve for that.
Okay, and I like to add one thing, that after you have anastomosed that nerves, the axon that was there, it has to create the myelin again, because when it was cut down, the myelin has gone. It was eaten up by the phagocytes and all. So when you do the anastomosis, and the myelin, when it reappears, the Schwann cells remake the myelin. It is not of that much, what we say, quantity. It is not like before. So the strength that the arm was having the strength before like when the patient was normal, it won't be of that much strength. The patient arm will still present some weakness. So to tackle that, can the physiotherapy approaches and the arm exercises, I think that should also be continued to increase the strength of the arm after the operation, because after the operation the patient is not perfectly normal. What I know, that there is always a loss of strength of the muscles. Yeah.
Okay, so guys, we are running out of time. So I will request one by one to introduce yourself and your subject, because for Inspiring Minds coaching. So
Okay,
yeah,
I am
starting
Sawan
from
Singh,
the
and I am okay. You start.
starting from the general surgery, Mr.
Okay,
Stup, sir. Yeah.
Okay, I am Kaustubh Kakade. I am from MUHS Maharashtra, India, and I am a fourth year MBBS student. I
okay,
am going to discuss general surgery and some part of systemic surgery with Inspiring Minds.
okay.
Okay.
Nice
Now,
to meet you.
Hello.
Yeah,
now, Sawan, say.
and okay. I am Sawan Singh, and I am third year student in Ternopil National Medical University, and I am, educator of pathology in Inspiring Minds.
Samkit, please.
Oh, I am Samket, and I have just completed my first year at Vinnytsia National Medical University in Ukraine, and I'll be sharing the knowledge of anatomy via Inspiring Minds platform.
Yetanji, up.
I am Yatanjeet and I am in a fourth year. I just completed it and now I am at KNMU, Kharkiv National Medical University, Ukraine.
Okay,
Okay. So, guys,
nice to meet you.
my name is Shivam. I'm third year medical student in Ternopil National Medical University. I'm educator here for the microbiology, and we have one more educator here, and unfortunately, he is unable to join us today, Rishabh Goel, and he's teaching biochemistry. And so, guys, hope you enjoyed. I think we enjoyed this discussion. See, guys, and for those who are watching this right now, you can comment in the comment section that if you want any topic for us to discuss, or you can also join this meeting with us in the next session, and we will be happy to help you and happy to clear all doubt whatever you have. So see you all guys next time. Okay,
Okay,
bye bye.
okay.
Bye
Have a
bye.
good day. Bye bye.